Good morning, everyone. Myself, Dr. Asmita, standing in front of you to present my topic on ocular manifestation among patients having demyelinating disorders. A brief introduction about it, that demyelinating disorders include multiple sclerosis, neuromyelitis optica, and anti-MOG disease. Ocular manifestations associated with multiple sclerosis include optic neuritis, which presents as visual blurring, decreased color perception, pain, and double vision. Characteristic MRI findings include the Dawson fingers, neuromyelitis optica. It is characterized by inflammation of central nervous system. Its association with aquaporin 4 immunoglobulin G antibodies distinguishes it from other disorders. Hallmark features include severe attacks of optic neuritis and longitudinally extensive transverse myelitis. Bilateral visual symptoms, recurrent optic neuritis, or the presence of other autoimmune disease can raise suspicion for NMO-related optic neuritis. Anti-MOG disease, that is anti-myelin oligodendrocyte glycoprotein disease, it's another demyelinating disorder. Patients who are seropositive for anti-MOG disease, they are at risk for bilateral synchronous optic neuritis and myelitis. Optic neuritis can be bilateral and produce severe visual loss, and myelitis can be severe and transverse. Early diagnosis and appropriate management are crucial to prevent systemic complications. Aim of my study was to study the ocular manifestations among patients having demyelinating disorders. Inclusion criteria was that all the patients presenting with features are included with or without ocular manifestation, and exclusion criteria was that the patient of optic neuropathy due to any other cause was excluded. Coming to methodology, a complete history was taken, followed by a complete general physical examination, and the ocular examination consists of visual acuity, pupillary reflex assessment, posterior segment examination, visual field analysis, fundus photos, and optic nerve head evaluation. Results of my study were that majority of the patients were found in the age group of 41 to 50 years, followed by 31 to 40 years. The mean age overall was 38 years. In MS, it was 36 years. In NMO, 42 years. And in MOG, 33 years. Majority of the patients were found to be of MS, followed by NMO, followed by MOG. Majority of the patients were female, that is 73%. Majority of the patients had abnormal CNS examination, and these were mostly associated with multiple sclerosis. Motor symptoms included hemiparesis, paraparesis, quadriparesis, whereas sensory symptoms included numbness, paresthesia, tingling sensation. Around 46% had visual acuity, had deranged visual acuity, and around 23% had visual acuity less than 6/60. Around RAPD was seen in 50% of the patients, and extraocular movement was restricted in 3 eyes. One of them had lateral rectus palsy, and another 2 had the partial third nerve palsy. Color vision, it was defective in 35% of the patients, and visual fields abnormalities were seen in around 20% of the population, and visual field abnormalities include central scotoma, enlargement of blind spot, generalized constriction of field, and superior quadrantopia. On fundus examination, partial optic atrophy was seen in 51%, and hyperemic optic disc was seen in 10%. Now coming to various ocular manifestations seen, among MS, optic neuritis was seen in 25%, partial optic atrophy was seen in 56%, and nystagmus was seen in 3 patients, whereas among NMO, normal patients were around 14%, and optic neuritis was seen in 35%, and partial optic atrophy was seen in 50%. And among MOG, optic neuritis was seen in 57%, and partial optic atrophy was seen in 42%. So coming to type of optic neuritis, papillitis was seen in 6% of MS and 14% of NMO and MOG, whereas retrobulbar neuritis was seen in 18% of MS, 22% of NMO, and 43% of MOG. There was no neuroretinitis in my study. Coming to lab investigations, oligoclonal bands, they were positive in 56%, anti-NMO antibody were positive in 71%, and anti-MOG antibodies were positive in around 100% patients of MOG. Various MRI findings include MS, Dawson finger sign, hyperintensities in periventricular, juxtacortical area, and optic neuritis. In NMO, MRI findings were hyperintensities in the region of aquaporin 4, chiasmal involvement, bilateral optic neuritis, long extensive transverse myelitis, and normal. And in MOG, they were bilateral optic neuritis and normal. Now coming to discussion. It was a prospective hospital-based study, and total 37 subjects were included. And I would like to emphasize on the various ocular manifestations. That was that ocular examination was normal in 13%. So that means that not every patient of demyelinating disorder has ocular findings. And on dilative fundus examination, optic neuritis was seen in 35%. Papillitis was seen in 10%, retrobulbar neuritis was seen in 24%, and there was no case of neuroretinitis, and partial optic atrophy was seen in 51%. So the conclusion, the pattern of demyelinating disorder was MS, NMO, and MOG. And I would like to say that in addition to MS, ocular manifestations were also seen in NMO and MOG. Therefore, anti-NMO and anti-MOG antibody should also be done in patients with optic neuritis to diagnose these entities, especially in bilateral and atypical cases in addition to MRI. Thank you.
How will your management protocol differ? So how will your management protocol differ for a normal optic neuritis patient as versus MOG positive or NMO positive
Uh,
optic
since
neuritis?
since a patient with optic neuritis, they have lesser chances of relapse as compared to a patient with NMO and MOG. So therefore, a patient with NMO and MOG will keep on follow-up visit. We will keep the patient on immunomodulators also. Whereas in a normal patient of optic neuritis, we don't do that. And moreover, there are more chances of relapse. There are more chances of recurrence in NMO and MOG as compared to a normal one.
So so regular follow-up is what you were trying to say. And immunomodulators, would you like to start it at the first instance or with the first episode of optic neuritis?
In NMO, it is started in all the cases, whereas in MOG, it is said that immunomodulators are started if the it is not started if the episode is first episode and it has completely recovered. But if there are multiple episodes, then it is started in cases of MOG, whereas in NMO, it is given in all patients.
So, in your practice, or if you are treating a case of optic neuritis, you would like to do the entire paneling, whatever investigations that you've mentioned for all the cases of optic neuritis, or only when you're suspecting a bilateral or an atypical?
Only in atypical cases, and if MRI is suggestive of NMO and MOG, like if there is perineural enhancement, if there is optic chiasmal involvement, not in all cases, and if the cause is not found, that time I think we can go for anti-NMO and anti-MOG, since these tests are also costly, around 8,000. So
8,000
yes,
per test, right?
per test. So that's why.
Also, what are the features that would be suggestive of atypical optic neuritis? How would you, which patients would you label as atypical optic neuritis?
Atypical optic neuritis, when we call a patient that when they have the like severe visual loss at the onset, there is bilateral optic neuritis, and MRI is suggestive of perineural enhancement or optic chiasmal involvement is there, and poor recovery is seen, and the patient is dependent on steroids that time. Uh, bilateral, bilateral is there. Huh, but-